All right, morning. I'm going to be talking to you this morning about bone stress injuries in athletes. We'll start off with a case presentation, talk more about diagnosis, then management, and finally finish up. So NC is a 17-year-old male with throbbing pain in the anterior lower leg, worse with activity. Pain developed gradually while running, and it worsened with increased activity, persisted for a short while after he stopped as well. Located mostly on the anterior mid to distal right lower leg, and the symptoms began about 3 months prior to presentation in the office. They worsened in intensity and frequency over the past month. Currently, he reports persistent but dull pain during activity, mild swelling, which is worse on hard surfaces. Considering his other pertinent history, he's a cross-country runner for the past 3 years, and he runs about 40 to 50 miles per week before the pain started. And the only treatment that he's had so far is stretching, compression sleeves, and ice. On exam, he's focally tender at the anterior tibia. He's got mild diffuse swelling in his lower leg, and the rest of his exam is unremarkable. On imaging, we can see here that his x-rays show really no pertinent findings, but his MRI does show increased signal in the mid to distal third of the anterior tibia, all on the top-down view, frontal view, and the side view. So this is a classic presentation of a male with a right tibia bone stress injury. What are bone stress injuries? These describe a spectrum of injuries, including tibial periostitis, medial tibial stress syndrome, stress reactions, and fractures. And this is all, again, a spectrum of disease that happens as the intensity or the activity worsens. This occurs from an imbalance in bone remodeling in which microtrauma outpaces the ability of the bone to heal. We see this normally from abnormal cyclic loading, particularly in competitive athletics and military training. The threshold of this loading can actually be lowered by nutritional factors, hormonal factors, or anatomic factors. We know bone stress injuries is an umbrella term for many different kinds of conditions, and you'll hear the terms such as stress fracture, bone marrow edema, insufficiency fracture, bone contusion, impaction fracture, all of these kinds of terms that are a little bit more specific and include things like trauma or degenerative disease, but basically fall under the same moniker. And a lot of times we'll see these mostly in radiology or MRI reports. Females are more prone to getting bone stress injuries than males, about 2 to 1. We can also see them in persons of extreme body weight, either very thin or very overweight, mostly in Caucasian non-Latinos. And most bone-specific stress injuries occur in the lower leg and in the foot. Retrospective reviews have shown that bone stress injuries can occur in up to 0.15% of all injuries, but this can be up to 20% of all injuries, musculoskeletal injuries in track and field athletes. Bone stress injuries are also high in military recruits. There's an average incidence of 20 in 1,000 stress fractures in the first 6 months. Female recruits have a 4-time higher risk of bone stress injury in the first 6 months as well. Nutritional factors play a big important role in BSIs. If we look at the relative energy deficiency in sport, this is an umbrella term to talk about energy availability that's defined by the amount taken in or the amount ingested as well as the amount of energy expended. And if anything that's lower than a certain threshold can cause disruptions in immunological, gastrointestinal, cardiovascular, psychiatric, developmental, and endocrine systems. There is evidence to suggest that the optimal energy availability, especially in women, should be about 45 kcal per kilogram per day, and anything under lower than 30 is a low threshold and risk for disruption of any of these systems. REDS is also an umbrella term for female, or I should say came from female athlete triad, which includes eating disorder, menstrual dysfunction, and low bone mineral density. A recent review shows that about 29% of collegiate female athletes were placed as high as moderate or high risk for a triad, with those at a moderate risk 2 times more likely to have BSI, and those at high risk 4 times more likely. Other nutritional factors we have to consider are vitamin D and calcium deficiencies. Recommended daily intake for adults is listed here. And the therapeutic bone levels we see are typically range from 50 to 100, 50 being the lower end for sedentary healthy adults, and 100 being more on the normal end for competitive athletes. Matter of fact, a systematic review of over 2,000 athletes showed that 56% were considered vitamin D deficient, which correlates to a level of about 80. In NCAA D1 athletes, the rate of stress fractures are 12% higher in athletes with vitamin D levels less than 100. Other metabolic and anatomic conditions to consider are celiac disease, inflammatory bowel disease, osteogenesis imperfecta, as well as anatomic variants such as flat feet, increased Q angle, limb length discrepancies, but perhaps the most or the strongest risk factor for future bone stress injuries is having a prior bone stress injury. There are a number of other modifiable factors that we look at that are listed here, things such as inappropriate footwear, a rapid increase in training, extremes of body size or composition, and type A behavior. BSIs can happen in a number of different places, with the tibia being the most common and the foot second. There are many different types of stress fractures, and in certain athletes, we'll see some more commonly. For example, march fractures, or dancers who have on point or who practice on point, like in ballet, we'll see a preponderance of metatarsal fractures. In sprint, jump, and hurdle athletes, we'll see BSIs mostly in the foot, in the navicular and calcaneus. And middle and long distance runners, we'll see these BSIs mostly in the lower leg and the tibia, as well as the femoral neck and the sacrum. BSIs present as dull pain. This worsens with weight bearing or activity, not necessarily trauma related. Localized swelling may be seen, as well as tenderness or focal tenderness at the injury site. Periosteal pain may seem like BSIs, such as shin splints. On imaging, we usually obtain x-rays, and these are mostly negative but may show evidence of stress fracture or bone remodeling later on. Eric and Drs. Buckley and Gatt have previously published on the efficacy of obtaining x-rays in the office and their utility for helping with guiding treatment for BSIs. MRI is the most sensitive and specific modality, though. It's more used in favor of bone scans, which were previously used, but which uses more of radioactive isotopes to help with the diagnosis, and so is fallen out of favor to some extent. CAT scan and ultrasound are not used as much to help. MRI grading systems have been developed. Initially, they were made for medial tibial stress syndrome, but have been applied to other BSIs as well. Grade 1 shows more of a soft tissue kind of inflammation around the bone. Grade 2 shows mild bone changes in the marrow. Grade 3 shows more extensive bone changes in the marrow. And grade 4 shows marrow changes along with cortical involvement, and of course, grade 4B being that dreaded black line that we always hear about. What do we do about these? There's non-operative treatments and operative treatments. Treatment is typically non-op. We start by modifying weight bearing, whether using crutches for non-weight bearing or partial weight bearing, as well as possible immobilization with a walking boot, cast, or hard-soled shoe. Afterwards, once the initial modified weight bearing period is over, we increase physical activity and return to sport. Non-operative locations of BSIs are seen in the following locations, such as the posterior medial tibia, tibial plateau, the navicular, metatarsals. All of these are treated non-operatively with the modalities as above. Timeline for non-operative treatment typically centers around cessation of athletic activity for about a month. During this month, protected weight bearing may be instituted, and afterwards, progression starts at 50% of the normal pace, with incremental progression in the weeks to follow. If pain is noted during this, halt the progression and go back to the previous pain-free level. Operative treatment is centered around fracture patterns that have a higher risk for delayed union or non-union based on anatomic location and fracture line. So for the tibia, we see it mostly at the anterior tibia, again, that dreaded black line that we see in that first photo. For femoral neck fractures, we could see it on the tension side, which is the superior portion of the femoral neck. Sometimes we'll because of the delay in return to sport, we'll consider fixation for elite athletes to have a quicker return to sport, such as in the navicular. There are other treatment options, such as shockwave therapy and orthobiologics, but there's limited evidence to support these at the present time. Rehabilitation for BSIs focuses mostly on physical therapy, cross-training and aerobic fitness, vitamin D evaluation and supplementation, as well as evaluation for relative energy deficiency and female triad, as well as possibly a DEXA scan if needed. Of course, prevention centers on education of athletes, families, as well as the training staff, appropriate and gradual loading of activity and not making rapid increases or jumps, optimizing nutrition, and facilitating bone recovery. So what do we do for our patient? NC's MRI revealed grade 3 Fredrickson changes, so extensive marrow edema with no cortical involvement in the right tibia. He was made weight-bearing as tolerated, as he wasn't really walking with a limp and had no pain while ambulating. We did stop all athletic activity for 1 month with a progression of 50% intensity and frequency after the month after that, and slow progression to full activity as tolerated. He did receive physical therapy, and we got his athletic training team involved, as well as perform extensive education with the patient and his mother regarding his diagnosis and tips for prevention. His pain improved significantly after the first month, and he was pain-free and back to full participation in cross-country after 3 months of conservative treatment. Some key diagnostic tips that we look for: suspect BSI when skeletal pain develops after recent increases in training load, especially in target areas. Palpate the painful area to localize. Request an MRI to confirm presence of BSI and grade severity. An MRI grading and anatomic location can guide treatment and time for return to sport. In conclusion, BSI is a spectrum of disease and usually presents as dull pain, worse with activity. Have a high suspicion for BSI with track and field sports, recent changes to training, female gender, as well as extremes of BMI. BSI can account for 20% of musculoskeletal injuries in track and field, and establish a multidisciplinary network early, including the athletic training staff, physical therapy, and the physician to agree on rehab and return to sport. Thank you.